right. Hi, my name is Lindsay. I'd like to welcome everyone to the fourth virtual town hall hosted by the Utah Referendum Citizen Lobby, previously known as the 2019 Tax Referendum Group. We're hoping to expand the reach of both constituents and legislators by providing additional formats for legislators to educate and update those they represent, as well as to allow those being represented or affected by actions of legislators to provide feedback in a real-time setting. Representative Norman Thurston is our guest today. Representative Thurston represents House District 64. We're going to start by allowing Representative Thurston to provide us with an update on his activities in the legislature for this year. Following the update, you'll have an opportunity to submit questions with the Q&A panel. If the question leads to a discussion, we will unmute you so that you can interact with Representative Thurston in real time. Please remember for all to be respectful. We know these discussions can get emotional sometimes. As hosts and moderators, we will do our best to keep this event positive, constructive, and productive. And with that, Representative Thurston, I'll just give you a chance to give us an update on what you've been working on the legislative session and any introduction.
Yeah, that's very much. Thank you, Lindsay. So I'm most excited this session about House Bill 207 that I am sponsoring regarding insulin access. And so I just want to give you just a quick highlight as to why the bill is what it is, and then talk about where we're going with it and how it's going to work out. So I think everybody knows that that type 1 diabetes is a pretty significant chronic condition that if you don't have insulin, you essentially die. And there are about 50,000 Utahns that have this condition, and another 150,000 that have another form of diabetes who may eventually develop this. But that's not the problem in itself. The symptom is that 1 in 4 of people who need insulin to live are rationing or scrimping, or however you want to call it, and not taking as much insulin, which can lead to serious health problems. It can lead to blindness, kidney failure, death, and really bad things for people. We got looking into why that's happening. And there are 2 main barriers to people taking enough insulin. The first one is cost. Insulin can cost upwards of $2,000 a month per person. And so if you think about that, what if you have more than one in your family? What if you had a parent and 2 kids with insulin, 3 family members that need to take insulin? Most people, there's just no way that could happen for them. And a lot of uninsured people as well end up paying full price if they have a deductible. So they go to the pharmacy and they're being asked to pay full retail price. Another challenge that we ran into was that a lot of times people show up at the pharmacy and there's a problem with their prescription. Maybe they've run out of refills, or the prescription's expired, or your insurance company changed the brand that they want you to take. And the stock answer from the pharmacist is, well, you're going to have to go talk to your doctor and bring me a new prescription. But what if you're out? What do you do if you don't have any insulin? That just doesn't work for most people. So we wanted to come up with something that would remove those barriers so that people don't have to ever leave a pharmacy without enough insulin to get them by for the next 30 to 90 days. And that's what House Bill 207 does. And you know, that cost issue is kind of remarkable. When insulin was discovered, I think it wasn't invented, it was discovered less than 100 years ago. The initial production price was less than 2 cents per unit. Today, it's not only high, it's rising. In 2009, a vial of Humalog, which is a fast-acting insulin, cost $93. It's kind of bad in and of itself, but in 10 years, it's gone to over $300. So it more than tripled in the last 10 years. So we want to take a look at some ideas as to how we could provide some relief and make the system better. There are 3 parts to this bill, really 4, but 3 main parts to this bill. One is to change the way that pharmacists treat people with diabetes. If you show up at a pharmacy and you need insulin, we want the pharmacist to be able to give you insulin. The second thing is that if you have an insurance plan, we want that insurance plan to give you the opportunity to buy your insulin at low cost or no cost. And we've defined that in the bill 4 different ways. And if that's not possible, if you're not on insurance, or you're on insurance that's regulated or something else, I don't know if people know this, but the state's public employees health plan buys insulin for state employees at a 75% discount. Why can't we extend that discount to everybody who lives in the state? And so we're planning to do that one. And then 4th feature, it's not really a main provision, is we want to understand the insulin market better. So we're asking the insurance department to come back and give us a market study of how the insulin market works so we can craft better policy in the future. So just the current update is the bill has passed out of committee. It was a 13-0 vote. All members were present, which doesn't happen very often. So 13-0 with nobody absent. It's on the House board. It should be heard sometime on the House floor this week, if all goes well, and then we'll be off to the Senate. So that's the status of the bill, and that's kind of what I want to talk about today. I'm happy to talk about other things as well, but that's my main activity. And so with that, Lindsay, I'll turn it back over to you. We can take questions or have some discussion.
Great. So there are a lot of details involved in this bill, has a lot of complications, but one thing that I noticed is this week you had a meeting with representatives from Canada to discuss their pricing and possible importation from Canada. I just wanted to see if you could update us on that meeting and how that's changing the bill before we get into more questions.
So there's a separate effort going on to reduce the cost of other drugs. So insulin, of course, is important, but it's not the only one. And I get emails from people all the time say, hey, thanks for your work on insulin, but what about my drug? And many of those other drugs are much, much cheaper, up to 90% cheaper in Canada than they are in the US. And so I have been a proponent of coming up with a system to take those Canadian prices or drugs at Canadian prices and bring those to Utah so that people can get access to them. Utah just is geographically disadvantaged. It's 10 hours from Salt Lake City to the nearest border crossing and probably another half hour to the nearest pharmacy. And it's just not feasible for people to drive to Canada. If you lived in Seattle, it's no big deal. You can get across the border pretty easily. Or if you live in Detroit or Buffalo, New York, or Burlington, Vermont, and those are all northern border towns where people can get to Canada fairly easily. So the Canadian consul has been in contact with me on a fairly regular basis, wanting to know what it is that I'm proposing so that they can react and understand and be supportive. They really do want to be supportive, but they do have to protect their citizens. So after that meeting, one of the things that we know is that we cannot do a bulk purchasing program from Canada for insulin. It's not allowed under federal law because of the categorization of the drug. So we did talk about that, but I don't know if a lot of the viewers will know this or not, but if you can get to Canada, insulin that costs in Utah $350, in Canada costs $35, and about 90% less, and you don't need a prescription. So we had some serious conversations about how is Canada making that work? What's going on? Are there things that we can learn from that? There aren't anything specifically in this bill with insulin, but it's an ongoing conversation with regard to other drugs. How do we do that without upsetting the Canadian government to the point where they just shut down the border on drug crossing?
Hey, Lindsay, you were muted somehow. You can go ahead and talk now.
Oh, thank you for opening that back up. Thank you for that explanation as well regarding things with Canada. That's going to be a really interesting way to look ahead. We have a question from Rebecca Campbell, just to get us started, kind of in more of the details. There isn't a fiscal note on this bill at this point. What are we expecting it to cost? What kind of cost coverage is the state taking on in this case, or is it just directing the insurance companies to essentially compensate for the difference?
So I reviewed a draft of the fiscal impact yesterday with the fiscal analyst. We're kind of trying to refine it a little bit because it doesn't make sense to me. Public Employees Health Plan, to run the bulk purchasing program, it will cost them about $25,000 a year, but they can recover that in the form of just slightly. So we talk about, well, you'll get it at PHP's price plus maybe like 0.5%. They just need to get a little bit to cover their administrative costs. So that part won't cost the state anything. On the other side, we have the study that's the insurance department, and there's also the insurance department regulations. That looks like it will cost the insurance department about $15,000 to $20,000 a year. I think it should be less than that. Really looking through what they're being asked to do, they're not going to hire any new employees. They're going to have to fit it within their existing workload. And so it's not clear whether it will cost the state anything other than that we're going to have to dedicate some taxpayer-funded time to working on this program. So, but in the outset of this, it's probably not more than $20,000 to $25,000 a year, or if you include the PHP recapture of their cost to administer the program, not more than about $40,000 to $50,000. But most of that, again, all of that would be paid on the PHP side by the users of the program.
And so what that cost essentially, it's being moved back to the PHP, which is within kind of the insurance drug company system,
So if
like Pipeline, would they just be raising their prices for insurance generally to cover that?
no, so that's the great thing about it. So the PHP part of this, the bulk purchasing aspect, so people can get the PHP discount. There is no additional cost to anybody. It's basically, think of if you worked for a company that had a great contract for, let's just say, paper goods, and they're paying, $2 a ream for paper, and the company says, hey, anybody who works here can buy paper at our cost. We'll just sell it to you at cost. That doesn't cost the company any more money. And that's what we're talking about, is the PHP is already buying this for our members at cost, and we're just opening up to make that available to more people. So it doesn't cost the state anything to do that. It does do that. Now, you mentioned something else that is important. What does this do to insurance companies? So if your insurance company now has to provide insulin at low or no cost to the diabetics, shouldn't that increase the cost to everybody else? And CVS Caremark just published an analysis that they had completed. They're now offering what they call RX Zero as a program, where insulin patients pay zero. That's why, RX Zero, it's where the name comes from. And their study shows that the cost savings to the program from not having people have the downstream health impact of not taking enough insulin, preventing those future costs is more than enough to pay for the cost of the added insulin when you take into account that they're also paying a discounted price. So I don't really see that this is going to cause significant costs or hidden costs or unfunded mandate costs in the health insurance system. But part of that study that we've asked the insurance department to do is to keep an eye on that, to make sure that we're not blowing up the market in ways that nobody intended.
So especially seeing the way that downstream costs are affected, that if people have insulin, they don't cost as much to the insurance companies or others, later on. Why do we have an understanding on why there's such an inflation at the cost level at the beginning? That
Yeah,
you mentioned insulin went from like $93 to $300 in 10 years. If it's saving the insurance companies money to use your insulin properly, how are the incentives working for that? Why has it gone up so much?
Yeah, that's a great question, and that's something that will be covered in the study. But one of the things that we do know, I think people are familiar with the phrase, is that nobody should pay full price for anything, and that's what's happening with insulin. When you look at that $300+ per vial, no insurance company is paying $300 a vial. PHP is paying somewhere in the ballpark of $80, and other insurance companies tell us that it's around there, somewhere between $65 and $90, or maybe even $100. So no insurance company is paying full price. So the question is, well, who is paying full price? Who's paying that full list price at the pharmacy? And the answer is only people who are individuals who don't have insurance or who have a high deductible. Those are the people that are paying that full price. And so the kind of really the whole point of this bill is that let's give those folks a tool so that they don't have to pay full price either, so they can pull that down. I've talked to the manufacturers. The manufacturers never expected to get that full price from anybody. That's a story for a whole story for another day, as to where those list prices or those manufacturers suggested prices come from and why they're so high. But they don't need to collect that much money to be profitable. They are okay with a discounted price from everybody, and they're not going to be complaining that happens. And in fact, right now, if I were to buy insulin at $300 as a PHP member, the manufacturer that I buy it from would almost certainly turn around and send PHP a check for over $200. And so the money that I'm paying ends up in the pocket of my insurance plan. And that's kind of like the real mystery is this: why is my insurance plan getting paid a rebate when I'm the member paying out of pocket? And this is going to end that practice effectively in the state of Utah. I mean, we'd like to end that practice more broadly, but certainly for the insulins, that won't happen anymore.
Hey, Lindsay, may I please ask a question here on this topic? This is interesting because up until now, I was under the impression that the markup was happening at either the manufacturer or the middleman. But what you're saying makes it sound like the markup is actually happening at the pharmacy. Is that accurate?
Yeah, again, and it's a complicated structure that we have for the market, and I'll try to keep it simple, not go into too much detail. But the manufacturer sets a manufacturer suggested retail price, which they call the list price, and say that's $300. The pharmacy buys it from a wholesaler and then is expected to sell it at the list price. So whoever walks in the door pays $300 to the pharmacy because the pharmacy paid about that, a little bit less than that. So that money then gets collected, goes through the wholesaler back to the manufacturer. But the manufacturer doesn't get to keep that money because they have contractual agreements with the pharmacy benefit managers and with the health plans. They have to pay rebates on that $300. And the average rebate on insulin is 77% across all the health plans. So when a manufacturer sets a list price of $300, they know that they're going to be paying a real big rebate to somebody. They're not going to keep all of that money. And so that who gets to decide that it's 300 or that it's 400 or that it's 200 is technically the manufacturer, but that is driven by all of these contractual relationships that they have with insurance companies and pharmacy benefit manufacturers. And the pharmacy is kind of left holding the bag because they just have to pay whatever the wholesale price is, what's called the WAC, the wholesale average cost, and that's what they end up paying. They have it's not they have nothing to say about it. That's just what they end up paying. Did we lose Lindsay to the mute monster again?
I'm back. I wanted to give George, I didn't know if he's going to have a immediate follow-up with that.
All right, there you are.
No, that was a good answer, and I appreciate that. I work in an IT field. I understand the idea of list price versus real price when you're buying things like that. But I guess I didn't think that would apply to the medication market the same way, which is pretty mind-boggling, actually. So thanks.
You know, the medication pricing market is all messed up, and there's another bill. Representative Paul Ray has a bill that he's working on to help unmess it up, but it's really, really complicated. It's going to take us a while to untangle that knot and get it back to something that looks more like a normal marketplace.
I would like to see, you said you mentioned the federal government earlier. I would like to see some pressure put on our representatives up there so that some of the regulations preventing import from Canada or Mexico or wherever else we can possibly import these medications from. Because I think a lot of us have heard things like, well, in Mexico they sell the drugs from our same manufacturers for a lot less, right? Yeah. So it's not like they have their own sources. They're getting it from us, selling it cheaper. And anyway, I appreciate that. I don't want to hijack this discussion. So.
Right, but I think it is worth mentioning Mexico. We haven't talked about them yet, but Gina Rowe from KUTV went with a family. They flew to Yuma, Arizona, and walked across the border to Algodones, Mexico. And right across, you walk out of the border crossing. And again, walking, you don't even need a car to do this. There is a huge pharmacy right there, right across the border that caters to American medical tourists. And they walked in and they were able to buy insulin. I think they said at about $15 for a vial. And we're talking something in the US that would cost $300. And so they bought just large bags of insulin and brought them back and made those available to people. It was sort of a community assistance effort, but they figured, look, for $600, we're able to bring enough insulin to help several families that are struggling to have insulin for their kids for a couple of months. And so, yes, Mexico is another interesting case study as to why is the price so much cheaper in Mexico for medical care. There's a lot to that. By the way, next to the pharmacy is a dental clinic. People go there for dental work all the time. People who need significant dental work can cross over to Algodones and get world-class dental care. It's just as good as it is here, but at a fraction of the cost. So it's dental care, it's surgeries, it's pharmacy. It's not, no medical procedure is 100% safe. None of this is 100% safe, but people are doing it because they save money.
Those are private organizations across the border there. So.
Yep. A Mexican dentist licensed and regulated by the Mexican government, but they've decided that they want to treat Americans who are willing to walk across the border. And they make money, we save money. It's kind of hard to argue against international trade when both sides are winning.
Thank you. Go ahead, Lindsay. Sorry.
Great. So I'm wondering if your description makes it sound very simple. I'm sure there's a lot of details and complications going in the back end, but if this is trying to decide which question to settle on, like if this is seemingly this straightforward with insulin, what is the plan looking ahead to other drugs? And are we anticipating to have like kind of backlash from other states or issues within the country as insurance companies see changes happening in Utah that are potentially threatening to them and the financial structure behind medicine in general?
So yes, it is. It is a little more complicated, but it's not much more complicated. Reality is that, for example, Select Health, before I even announced that I had a bill file, they had already figured out their change in policy. They made their change in policy last July. They were already onto this. PHP also told me that they had made decision to move to the low cost, no cost pricing for insulin almost a year ago. So the private market is figuring this out. And in some sense, maybe you might say, well, then the bill's unnecessary because the private market's figuring it out. But this just kind of guarantees that they don't get cold feet and back out on us. Some of the companies, such as Aetna, and as I would call them out as being a good actor, because they're part of the RX Zero movement, they're going to make that available nationwide. So if you live in any state, you'll be able to get the Aetna RX Zero price as an employer for your members. So yeah, I think this spreads to other states fairly quickly as people look to Utah and say, wow, you guys have got something working over there, and it is helping people with diabetes, and it is not costing as much money as everybody was afraid it was going to cost. In fact, it may actually be saving money. Now the other part of your question is, well, how do we extend that to other drugs? It's a little more complicated because insulin is quasi-competitive. I don't want to call it a competitive market because it's really not, but there are three major manufacturers. Most of the drugs that they're selling are off patent, and so there's not that patent protection. You have some hope that this could work out there. I do think over the next few years we will see more manufacturers enter the insulin market because even at the discounted price, they're still doing just fine. But what about other drugs like Humira? Humira is a patented drug. You can only get it from one company. There are no alternatives. They're going to sell it to you at whatever price they want to charge, and they don't have to offer any rebates. So how does that work? And so we need a different solution for a different scenario. When you've got a patented drug, the manufacturers are just choosing to charge a super high price. How do you deal with that? And I think as we keep working on pharmaceutical pricing, we will discover these different bins, if you will, of kind of market structures where we need to act and where we don't. I mean, I haven't had anybody call me and tell me that they can't get generic Tylenol. I mean, generic Tylenol is pennies. It's nothing. That market works really, really well. So generic Tylenol or ibuprofen, those markets work really well. The same thing is true of the generic statins. So if you want to think of Lipitor or the similar drugs, Zocor, those things are all available to people at virtually no cost. Pennies on them per month. Matter of fact, many insurance companies cover those at zero cost because it's just not worth collecting the money. So different drugs, different scenarios, different market structures will cause us to think about it. But I would just going to put a pin in this one. When you look at blockbuster branded drugs where people are coming on and charging $100,000, $300,000, just exorbitant amounts of money for a brand new drug, we need to think about what is going to be our policy to make sure that market exists, because we do want the drugs to be developed, but in a way that works so that people can actually afford to get those treatments.
I think that leads into probably my most critical question on insulin, and probably the most frequently asked question when we proposed this town hall. We had a lot of people ask us to ask questions who couldn't be here themselves. Can you explain why insulin is still patented, even though it's been around for a long time? And also, what role the state has to play in that, what role the federal government has to play in that, and if you'd be willing, what would you like to see at the federal level in all of that?
Sure. So the first patents for insulin were issued in 1923, And the insulins in 1923 were derived from animals. So they were the first animal that they used was a dog. Then they later were using cows and pigs. Turns out that insulin is not, I mean, it's produced fairly similarly across many species. And so in 1923, that patent was issued. It was promptly sold back to the University of Toronto for about $1. I think it was $1 per researcher, so it may have been $3 if I've got the pricing right. But the idea was that they weren't going to make money off the patent nature of that. And so for decades, that's how we went. It was animal based and it was very low cost. But then in the 70s, medical research got involved and said, hey, we can do better than this. We can create what are called human analog insulins or human insulins. And so they developed those insulins in the 70s and patented those. Those patents have pretty much expired at this point. There are a few more recent ones that haven't expired, but the patent effect of insulin is significantly diminished because there are no real patent barriers for getting the insulin, and which makes it kind of one kind of wonder, how is it that this is so expensive if there are no patents left? But that is a federal government thing. I do think, and I've heard people argue this before, that the federal government has done effectively the same thing as patenting by making it really hard for people to enter as manufacturers. They have not approved any new insulin manufacturing in, I think it's been over 10 years, maybe 15 years. So they're just not, they're not moving forward with helping new entries to the market. The cost of producing insulin for one vial, the actual cost to the manufacturer, we don't know exactly what it is, but we think that it's less than $10, somewhere around $6 maybe of actual cost to make a vial of insulin. And they're getting on average around $65 to $70. It's a pretty good business model. If you can make something for $6 and sell it for $70, you're doing just fine. And the question is why isn't somebody else jumping in and making it for $6 and selling it for $50 or selling it for $40 or $30? You can talk that all the way down to to 10. If I can make something for $6 and sell it for 10, I can be profitable even with those slimmer margins. And we think a lot of that has to do with FDA policy in approving new manufacturers, and that's the one pressure I would like to apply. Or I don't know if I could, we can't do this as a state, but it would be nice to be able to think that there are companies out there that would like to jump into this market and compete. And I really do think that we will see more insulin manufacturers entering in the next 2 years.
So I know that there's legislation pending right now in the House on capping insulin, pretty similar to what you're doing here at the state. Is there a legislation going on to manage the patent stuff? And if there isn't, can you give us an ideal version of what you'd like to see? Because I know that this is not just a Utah problem. This is a problem across the country.
Yeah, so patent reform is a topic that comes up every once in a while, but I think everybody who's listening can appreciate how much money pharmaceutical research companies will spend in defending the current patent system. So I don't have great hopes that the federal government is going to engage in any serious patent reform in the near future. The current administration has been very interested in talking about it, but I just haven't seen any action, partly because it requires Congress to take action and partly because there's a lot of resistance from the industry. And there are good reasons. I mean, we have a patent system for a reason. From the very beginning, the idea was to encourage innovation. That's why patents exist. But when it comes to pharmaceuticals, there are some features of that patent system that need to be reviewed and possibly changed.
I know it's a question to answer. I also know that we've got people dying, and so that's the reason that you're doing what you're doing. And we also have so many really critical questions going on around it. I think that just to give you the feedback from what we've seen from so many constituents, patent reform is the #1 thing we have seen requested in this area. And I know that that's a state thing and not a federal thing, but I also know that you have access to our federal legislators. And so if you would be willing to carry that message up, patent reform is a delicate balance, but something that we need to see before we see more people dying. So, We also have access to our federal legislators, and it's a message that we're carrying as well. But I think you probably have a pretty strong voice, so I'd love to see where you could advocate in that area.
Yeah, I think so. I think the whole idea with pharmaceutical costs is what Clayton Christensen called, disruptive innovation. And anything that we do at the state level that disrupts the markets and causes people to rethink how things have been done will spur innovation. And so that's what I'm hoping with House Bill 207 is that this disruption will just spur innovation. It will cause health plans and health insurance manufacturers and everybody to think about different ways of doing things that provide better outcomes for society. And we just not accepting the status quo.
I like that. I think that could be the outcome. I know that there's other people worried that it could cause shortages. Is there any real worry about that?
I'm not worried about causing insulin shortages. There is plenty of worldwide production. I mean, these are produced in places that are not, I would say, like not subject to. So the insulin is produced in the U.S. in Indianapolis. I think there's a facility in St. Louis area, and there's another one in New Jersey. So we're not worried about political disruption. It's not like we're depending on China to supply all of our insulin for us. It's domestically produced. It's here. It's available. And the ingredients, the process is not subject to kind of disruption either. What they need to make this, they have, and they will continue to have it. So, barring some sort of major catastrophic event that covers all of the eastern United States, I'm not worried about the manufacturing plants not being able to keep up with demand worldwide. The other thing to notice is that the demand worldwide is fairly constant. The number of people with insulin is a fairly stable. You can predict that number of people, and you can predict how much insulin they're going to need. So yeah, it's pretty straightforward for the manufacturers to know how much to produce and be able to keep up with the worldwide demand.
In terms of the detail, we're really getting into the details of the bill. We had some questions from others who weren't able to be here, asking why there aren't any discounts for 90-day prescriptions. If there are somehow built into the bill that we weren't able to see, as pharmacies often use that type of a plan, and if there's any plan allowing for testing supplies that require multiple testings a day without further costs.
So those are both very good questions. So in terms of the 90-day supply, we're not requiring the insurance companies initially to allow people to do a 90-day covered benefit. Most of them will for insulin because they understand that making people go to the pharmacy every 30 days can be problematic because that's just one more barrier. So most of the plans I've talked to are looking at how to make a 90-day supply available. And in the bill, we create the framework for that to happen so that if a person has a prescription, you can always obtain a 90-day supply. Now, the question is will your insurance plan cover that? And will they cover it at the lower cost? And that's where I think that the insurance companies are going to have to step up to the plate and make that happen. So yes, so there is work on that frontier. We want to let the plans think about that, let them innovate. They'll get it right. I've had enough conversations with them to be fairly confident that they will figure that out. And if not, it's not the worst thing in the world for people to have to go back every 30 days. I understand that that's a barrier and that does have negative consequences, but it's something that we can tolerate for now. And then I just forgot the second part of your question. So could you maybe just give me a reminder real quick?
Yeah, the second part was in addressing testing supplies and whether costs on testing supplies are being impacted.
Yeah, same thing. As the plans are looking at this, they understand that testing supplies are also part of this deal. We didn't want to write that into the bill up front. We'll let them figure that out. And I think most of the plans are on to the fact that if you don't have, depending on your situation, if you have a continuous glucose monitor or whatever you need to be able to know how much insulin to take. And so they're aware of that. We'll watch that for the next year. And if we see innovation and we see good behavior, then we won't need to regulate, which is my preference. My preference is that the plans will figure it out and do the right thing on their own. But we've sent enough of a shot across the bow that I anticipate for the most part that will happen. And if it doesn't, we'll be back next year and we'll be addressing the testing supplies next year. And by the way, we do mention them in the bill. They are mentioned in there in the category of where pharmacists can switch you out. So if your doctor prescribes a different brand of monitor or tools that you need, the pharmacist can give you whichever one is cheapest. So there is a mention of that, so that there's a place marker for that, but we'll just keep our eyes on it and see how that goes.
So is this limited to specific brands then? It does mention that it's required to be lower tier insulin. How does that affect the various brands of forms of insulin that people require?
Yes. So there are two aspects of it. There are different forms of insulin, and then there are different brands of insulin. So you have long acting and short acting, or fast acting and long acting. So maybe that's the easiest one to talk about. And we treat those as separate things. So the insurance companies have to cover at least one insulin in every of the therapy categories: fast acting, long acting, and then there's some other things out there as well that I want to get into the details. But yeah, so from the different kinds of insulin, yes, they have to cover at least one in every category. Now, from the brands, and I've talked to pretty much everybody across the spectrum, both the doctors, the pharmacists, the patients groups. Once you talk about, for example, fast-acting insulins, there's not a huge amount of difference between, for example, Humalog and Novolog. They essentially do the same thing. And it would be extremely rare that you would find a patient that needs a specific brand. And by only requiring the insurance plans to cover one of those, that helps give the insurance companies market power to negotiate an even lower cost. So most of the plans will pick one of them, one of the three, for example, fast actings, and they'll say, this is the one that we get the best deal on, and that's the one that you're going to get the lower no cost payment on, which is why it's important for pharmacists to be able to switch your prescription. So if your doctor says Novolog and you get to the pharmacy and say, hey, but your plan is a Humalog plan, you can just make that switch seamlessly, automatically, and ready to go, and you're fine. And I haven't found anybody yet who's given me a good case as to why one specific brand needs to be protected. In fact, that's kind of the magic of this, is it drives competition. It allows a company like CVS, who has 80 million members, to negotiate with Eli Lilly, the producer of Humalog, and saying, look, we've got 80 million members, and we're perfectly happy to make you our number one choice, but you got to give us a really good deal. If we're going to make you number one, you got to give us a deal. And that's that's our best hope at bringing competition into this marketplace and forcing those prices down.
For that, Representative, I want to make two comments. One is, if you've joined late, please know that even though you're muted, you can submit your questions in the Q&A panel. So please feel free to do that. And if needed, we will unmute you. Regarding the different manufacturers, one thing I can say is I actually had a discussion with an individual who said that one brand worked for their child and the other one didn't, right? So maybe it's a corner case, but it seems like there are people who have that experience. And I know we can't cover everything in a bill, and it's probably not the right place to cover it. That's why it's better to just make the systematic changes than having to legislate every little piece of this. But just know that even though it's not common, I've already heard that does exist, that this certain brand isn't working for me, even though they're both the fast acting kind and the other brand is. So
yeah, and they will need to work very carefully with their physician, because if their diabetes is that sensitive, I assure you that they have additional other complications that cannot be solved easily with a bill. So that is a very complicated medical problem. They just need to work closely with their healthcare providers.
Yeah, thank you for that.
I have another question
Lindsay.
from,
Yeah.
Sorry about that. I have another question from Rebecca Campbell. She's asking, what about people who are not covered under insurance plans at all? Would this legislation and the caps still apply to them?
So the caps do not. So the part that has the caps and the low cost, no cost, that's only for people who are commercially insured. And by the way, there are people who are insured, who are insured, but they're insured by a self-funded plan. Similar problems. We can't regulate them. So that highlights the need for the bulk purchasing component. So if somebody is uninsured, or if somebody is on a health plan that doesn't have to comply with state law, they can always, any of those people can always contact PHP and get enrolled in the bulk purchasing program. It's not a perfect solution, but when you're paying $400 for something or $350 for something, and all of a sudden it becomes $80, that's a huge help. Again, it's not a perfect solution because $80 is still a fair amount of money, but in talking with the patients who are paying $350. I said, well, would 80 help? And they're like, that would be life-saving to be able to save that much money. So yes, so there is an option for them. And I do want to point out, I don't think enough people are aware of community health centers. And the reason why this is important is community health centers, some of them do have capacity to take on more patients. Right now, people can go become community health center patients. And if your prescription is obtained through a community health center, then you can go to what's called a 340B pharmacy and get those drugs at cost. And at cost means about $10. So community health centers are designed as a safety net healthcare provider for people who are uninsured or who are underinsured. If people go to them, and there are no qualifications, there are no restrictions, anybody could go. I could go. They would let me be a patient there. You could go. We all could go as long as they have room for new patients. And then the patients who are getting their healthcare through the community health centers are paying around 10, I think maybe 15 by the time you add on the pharmacy fill charge per vial, which is significantly less than 80. So if somebody says, well, I can deal with 80, that's fine, do that. If 80 doesn't work for you, then get involved with the community health centers or the 340B pricing and use those tools as well. The University of Utah has clinics around the Wasatch Front. They also have access to 340B pricing. It's a little less clear how that works, but if somebody is also struggling, if they have a way of paying for that office visit at a University of Utah healthcare clinic, they can get access to also significantly reduced insulin through those clinics. But there's not enough capacity in either of those systems for everybody, which is why we have to create multiple channels and multiple pathways.
Thank you. We have another follow-up question as well with that. Becca says she used to work for a health insurance company and often received phone calls from parents concerned about having more insulin on hand in case of an emergency for their family members, and their insurance plans wouldn't allow that. Is that something that we can address in this bill, or that is addressed in the bill?
Well, so that's the issue of stockpiling. And insurance companies don't like to pay for stockpiling because people want to, and I can see why, I would too, to build up a stockpile so that if something happens, like there's a blizzard and you can't get to the pharmacy or whatever. So in the bill, we always allow people to get a 90-day supply. So that should create some flexibility so that you don't have to get down to your very last vial before you go to the pharmacy. When you do 90-day supplies, you don't have to run it all the way to zero. You can often go when you have a 30-day supply left. And so you can create a 30-day buffer in your system. So again, I'm not entirely sure how that's going to work for everybody because there's a lot of special cases out there, but our intent is to allow people to buy enough at one time to be able to have a reasonably safe buffer at home. And there are other things that people can do, but yeah, we need to make sure. And I guess there's a third option, which is physicians can write out prescriptions for a little bit more than you need. So suppose a person normally would need 3 vials a month and the physician writes out the prescription for 4. Insurance companies aren't going to give you pushback on that. If it's dispensed as prescribed by the physician, you can get an extra vial every month or 2 to kind of keep your stockpile up. That's another way of dealing with that.
All right, and but the cost savings isn't necessarily legislated for that 90-day.
Right. So all of these things are still subject to your insurance plan. So if your insurance plan has a requirement that you can only get 30 days at a time at a retail pharmacy, then you kind of have a sucky insurance plan. That's just kind of how it is. Every insurance plan should recognize that 90-day retail is best practice for insulin. The reason why they do 30 days is for drugs that you may not need in the future. I don't know of anybody who's currently taking insulin who may not need insulin in the future unless something really bad happens. That seems like a counterproductive way of structuring your plan. And I've mentioned that to the plans. We do need to get all of the plans saying, yes, 90-day retail is the way to go. Insulin is not, you can get insulin mail order, but it needs to be refrigerated. So it doesn't make any sense. It's expensive to ship. It just doesn't make sense. And so we need to get to the world where 90-day retail is the standard and that all health plans allow that to happen. But again, I wouldn't say these are not baby steps. This bill is far beyond baby steps, but it does not get us to the end of the road with all of these things that we need to get done.
Thank you. And you addressed this briefly earlier, but Taylor, we have a question from Taylor. Maybe you can get a little more detailed just in the specifics. She says, can you nullify federal import laws in Utah so we can fly planes from here to Canada or Mexico to get insulin at 1/10 the price? I know you mentioned going physically over the border in a car or walking. Is this not currently available to fly it?
Yes and no. So here's the thing. So if you and I wanted to hop on a plane tomorrow and fly to Vancouver, Canada, we could do that. No one's stopping us. We could go to a pharmacy and we could say we want to buy a bunch of insulin. Here's the credit card. We want to buy that. There's no prescription required, and we would get it at a Canadian price. They don't verify that you're a Canadian citizen to do that. And we could go back to the airport and get on a plane and fly home, and we would walk through customs and no one would say anything. So can that happen? Yes, as long as we are private citizens doing it on our own, nothing's going to happen. If the state of Utah as a government entity tried to create an official way of doing that, then Customs and Border Protection would stop the shipment at the border or at the airport or however we're doing it. So yeah, that's a yes and no question. I do want to point out that on not for insulin, but for other drugs, PEHP does have a program to facilitate individuals flying to San Diego, going across the border to Tijuana and getting some of these expensive brand name drugs, like I mentioned Humira earlier. We saved over $250,000 in 2019 by flying people to San Diego and driving them. We actually paid for the car to drive them across the border into Tijuana to pick up their drugs. That's about as close to the line as we can get in terms of just thumbing our nose at the federal government. We're delivering the patient to the point of care in a foreign country so that they can do this transaction on a personal level. We're just not ever taking possession of those medicines ourselves as a state agency and bringing them back and risking having that confrontation. So that's as close as we get. I do have a proposal this year to see if we can work with the federal government to allow us to do that in reverse. So instead of flying the patient to Mexico or Canada, why not just have that medicine flown from Canada to Utah? It doesn't make sense to me why I can fly a person to a foreign country to pick up a medicine, but I can't fly the medicine from the foreign country to the person. And we're working on that. Is another proposal that we want to figure out how to do that and not, because the only risk that we run in this whole program is that Customs and Border Protection confiscates the drugs. And so we just have to figure out how to make sure that doesn't happen. That is a nice question, by the way, of just pointing out sort of states' rights, and the federal government is not helping very much, or is not as much as they could. And so, yeah, due to federal inaction, that's why states are doing all of these innovative things.
Thanks for getting into
the question.
Go ahead.
Oh, sorry. Go ahead, Lindsay.
You can take it, Wendy.
Well, so in the tax referendum group, we have 26,000 people, and this was our most requested discussion. And we have a lot of people saying that this program that you're proposing is quote unquote socialism. And as you know, of course, socialism is the buzzword, right?
Yeah.
And for whatever reason, they didn't jump on this call to talk to you directly about that. And so I would love for you to just address that because I know that you're a Republican, and I know for sure you're not a socialist. So would you be willing to just address that directly so that the viewers who come on later and watch the recorded version of this would talk to you about, would be able to hear your response to that question?
Yeah, and we and the other sponsors, I and the other sponsors have gone out of our way to make this as much market-based as possible. We're not picking one manufacturer. We're not picking one health plan. We're not even buying the drugs for people. We're just helping people get access to markets that already exist and encouraging those markets to be more compassionate and more caring about their members. So, it is interesting. Select Health was already going there, and in some ways, Select Health would have preferred that we not get involved so that they could get some competition out of this. But we just shined a little light on saying, hey, this is what plans like Select Health, PHP, Regents, Aetna, this is what people are doing. And by the way, we think this is great policy. This is how all businesses should operate. It's good for people. You ought to move along with this. And yeah, there is an aspect of government regulation But at the end of the day, I just have to say, every single health plan that has come to talk to me about this says, we want to do this anyway. In fact, a couple of them said your bill's not necessary because we think every health plan in Utah will go this way eventually anyway. And it's like, well, then it's no harm, no foul. Let's just go ahead and put it down and make sure that you guys don't just, give this lip service, that you actually do take care of this. So yeah, it's pretty far from socialism. Socialism in this world would look like the state of Utah buys insulin from one manufacturer for everybody, and it's the only way that you can get it. You have to get it from us. And by the way, we're going to pay for it through taxing everybody and reallocating money. And none of that is happening here. The state of Utah is not buying for anybody other than the people who want to use our discount program. But even in those cases, we're not actually making the purchase and taking possession of it. We're just giving you access to our contract, so allowing people to join in with the state purchasing power. So yes, it's not socialism that I can see in any reasonable manner. It's pretty far from it, actually.
Thanks, Wendy. That was a good
I wanna-
question.
Thanks. I do want to pass on also. My dad is diabetic and is insulin dependent, and he is, he worked his whole life. He's using Medicare as his insurance, now, but having done, in his opinion, everything right his whole life and accessing insurance now and using appropriate retirement funds to pay for his insurance, he still cannot afford the price of insulin. And so I wanted to thank you for what you're doing, because I think this is the right thing to do for so many Utahns, and I appreciate it. I, by the way, am a Democrat and probably would be called a socialist by most people, but I think that what you're doing is the right thing to do, and it's going to help encourage the market towards appropriate pricing rather than be a socialist program, which, like you said, is going to take money out of taxpayers' pockets. So I think it's the best way to be doing this, and I really appreciate it.
Thank you.
Thanks. I have two questions to follow up on what Wendy just said. One is, would you be a proponent for putting a sunset clause on a bill like this? Because in 5 or 6 years, maybe somebody needs to relook at this and see if it's relevant or not, and instead of it just persisting. So that's one question. Go ahead and answer that, I guess.
Yeah, I don't think we need a specific sunset clause because we have the study. So in the study, the insurance department will be coming back within the next year and reporting back on what they're finding. So we have a natural opportunity and reminder. Sunset clauses are essentially just like post-it note reminders saying, hey, by the way, we did this 5 years ago. Should we look at this again? And too often, I think sunset clauses end up just being, oh, well, we have this sunset date. We just need to extend it. And nobody actually seriously looks at it. I think the study from the insurance department is a better way of approaching that, because they'll bring us more information. We should know more in the next legislative session than we know now. And we can say, did we do the right thing? Do we need to change what we're doing? And I would like to see that sort of discussion be top of mind for the next several sessions as we continue to work on pharmaceutical costs. So sunset date, I don't really like sunset dates that much for programs like this. Kind of signals to people that we're just going to try it and then it's going to go away, or that we're just going to automatically renew it. More likely than not, the legislature just automatically renews all the sunset dates, or somebody runs a bill to just get rid of it in 5 years. Like, well, just to get rid of the sunset date. So I prefer to make this an active topic of discussion through the requirement, in this case, through the requirement that the insurance department come back and report to the interim committee as to what they're learning in their study.
I appreciate the study being in there. I noticed in the first and second version of the bill, the study wasn't there, and it showed up in the third version. So thanks.
That was the suggestion of the health plans. They said, hey, the manufacturers are not even mentioned here. They should be at least mentioned. I said, yeah, okay, well, let's go ahead and mention them. Let's look into their business.
Very good. We only have a little bit of time, Lindsay. There's so many other bills that you're associated with, and one of them is HB 121, the income tax revenue amendments.
Yeah.
Something that you're prepared to talk about a little bit.
Yeah, so this is one of the informational dissonances in the tax reform is that there's this huge tax return. Like, we're going to cut income taxes. So much of that money was taxes that shouldn't have never been to belong to the state in the first place. So what happened when we had federal tax reform was they got rid of the dependent exemption on the federal return. State law says that the state will do the same thing that the federal government does on a state return. So hundreds of thousands of families across the state lost their dependent exemption and their taxes went up as a result of federal tax reform. Representative Quinn and I argued at the time that that money did not belong to the state and we should not keep it and we should give it immediately back to the citizens of Utah. But we lost because there were people who wanted to spend it, and so they spent it. And now 2 years later, they're saying, oh, well, let's give it back to the citizens and call it a tax cut. And I personally have a hard time seeing how keeping something that wasn't yours and then returning it could be called a tax cut. So House Bill 121 says that in the future, if this ever happens again, the legislature must either return it to the citizens or they must make a positive vote of the legislature to accept that money, and basically going on record of saying we're going to do a tax increase. And that I think that would have prevented that part of the fiasco from happening, which is that the money was there, we just kept it. We didn't say anything to anybody. We didn't even have to vote to keep it. It was just our money. We just spent it. And I voted against that every step of the way, fought against it, saying that's not our money. Let's give it back. Let's give it back. Representative Quinn was able to get a partial credit back last year, but I don't remember the exact number that he ended up with, but it was only about 25 or 30%. So a big chunk, if you will, of what was promised as the income tax cut wasn't really a cut at all. It was us just not stealing what we shouldn't have stolen in the first place. So anyway, that's a little bit of red meat for this group, I'm sure. Just something fun for you guys to think about.
Oh, yeah, I appreciate that. And fix that all the way. And sounds like there's pressure against it from the Senate, but maybe the House will pass it when.
The Senate was primarily responsible for not giving that back the first time around. They had a lot of funding priorities, and they viewed that as a readily available funding source. The Senate as a body, I'm not going to pin any one individual for this. I think if you just taken the votes, you would have got easily 15 votes to keep the money. And I've heard that's part of the resistance on giving this child tax credit back to people this year, is that those same people are resistant to give the money back because then they will either have to cut programs or promise to not spend it in the future. I'm like, yeah, you look at the surplus. There's plenty of surplus in the education fund. Let's just give the money back. Just put the political considerations aside. I know there's a lot of political soup involved, but let's just give the money back. It was never ours in the first place. We've spent it for 2 years. We shouldn't have. Let's just say we were wrong. We're sorry. Here's your money back. Thanks, guys. That's where I would do on that.
If you let us know who to talk to, we'd be happy to refer all of the folks who signed the referendum to chat with those Senate folks and give them our opinions, because we would love to. There's been a lot of very clear messaging from those folks of what they would like done with that money, and they would love to pass on their opinions to those same folks in the Senate. So
yeah, I don't know that I want to call out any specific names, but the people who would be the ones to contact would be those on the task force that voted for tax reform. Those are the people who are the public face of tax reform, and take a look at those folks. If those are the ones that voted for tax reform, they're the ones who can they're big boys and girls, and they can take the heat for this particular issue and be the ones that can answer to that.
We also want to take a second to thank you for your vote on SB 2001 and making it so that we could have a referendum, or even trying to prevent the issue in the first place. So I want to give you a second to just have thanks for that, or appreciation.
Well, I appreciate that. And I told people from the very beginning, I think that bill was flawed both in policy and process. And furthermore, it was hated by pretty much everybody in my district. So despite people saying, "Oh, you were so courageous," I really wasn't. It was an easy vote to cast no on that one, because I had studied it out. I knew it was bad policy. I think we hadn't followed a good process. And in the strange world where I would say, well, and I only want to do what my constituents want me to do, it's those things all lined up. But I think you all know that when I'm at the legislature, I do listen to my constituents. I listen to their input, but at the end of the day, I make my votes based on policy what's good policy and what's bad policy. And sometimes that's popular, which is always nice. But even if it's not popular, I still do what's right. In this case, that everything lined up. There was no reason I can imagine anybody should have wanted to vote for that bill. I still can't. I have colleagues here in Utah County, and I can't imagine for the life of me why they voted for that bill. But it is what it is.
We exceptionally appreciate your added dedication to listening and knowing that it was a bad bill, getting that feedback from your constituents right at the get-go and voting with them.
Thank you.
I have one last question. This just came up. I know it's not even a numbered bill yet, but Prop 4. Where do you stand on that?
So I heard this morning, I heard it this week, and I heard some more this morning that there are specific legislators that are in discussions with the people who proposed Prop 4. There are some issues with Prop 4 that would make it hard to implement. There are some vague definitions that need to be hammered out. I will react once I see hopefully they will come to a compromise and it will make sense to everybody that it's good policy going forward, but I'm going to wait and see what they propose before I make any judgments on that one. So I guess what I would say is I am open to the idea that there are things in Prop 4 that need to be adjusted or changed. I don't think that it needs to be repealed in its entirety, but those changes, I'm not exactly sure what will be proposed, and I'll have to react to those once I see the specific proposals.
I think that in general, the Utah voters are pretty sensitive at this point to their voices not being heard. So I'm not sure that they're going to see the small points. I think they're just pretty sensitive to not having their voices listened to at this point. So that's just feedback on that.
That's great feedback, and I understand that the challenge with legislation by initiative, well, with any bill, it's really hard to get something right on the first draft. You know that firsthand. House Bill 207, we've been through 3 drafts of it now, so it is hard to get it right on the first shot. I think there should be an expectation by folks that propose something that it could be subject to refinement in order for it to be workable. But the job of elected officials is to at least pay attention to the intent and the desire of those that put forward the initiatives, and do our best to implement it in a way that's responsible and workable, and that meets the intent of the voters. But requiring the law to be perfect as written that's not very realistic. And I know that's a hard thing for people a hard thing for us to message to people. It's like, hey, we get it, we understand, but we have to make some changes.
It's a pretty simple law, though.
Well,
Yeah, we want to be respectful of your time. I don't want to drag you through. This could be a long discussion. I don't want to make you late. So
thank you very much, Representative Thurston, for your time, for all of this explanation. I think we've got a lot of information people can come back on and review. We'll be posting this town hall online and issuing a report on it as well. So thank you for coming.
Thank you, everyone.
Thank you. Bye-bye.